Good evening, ladies and gentlemen. My name is Dr. Richard Arjun Kaul, and welcome to Nine. Today is August the 29th, 2015, and I'm talking to you from New York City, New York. The epidemic of pain that has gripped America for the last 10 to 15 years costs the economy $635 billion annually, both in terms of the treatments and therapeutic options that are employed to treat pain, but also in terms of the lost days of work productivity. Now, when we talk about pain, we're talking about the chronic variety, not the acute variety. Acute pain is a different pathophysiological entity to chronic pain. Acute pain occurs when, for example, somebody knocks their shin or breaks a bone. It's that pain the individual experiences in the 3 to 4 days after the event. A chronic pain syndrome is a syndrome that goes on for years, and quite often for which no quite definable cause can be ascertained. And the research and development into this very complex and costly arena indicates that it's to do with a resetting of the internal sympathetic and autonomic nervous systems. Now, those two terms refer to a specific part of the nervous system that control a multitude of bodily functions. Now, the medical profession has been increasingly focusing its attentions on finding solutions for the management of chronic pain. And within the therapeutic interventions, there's been an increased direction towards pelvic pain, primarily in females, but also in males. Now, pelvic pain has been one of those entities that has been ignored for many years, up until recently, because no real understanding of why it is that people experience pelvic pain was obtained. But some of the research is now beginning to focus on what I referred to before as the autonomic nervous system. And some of the groundbreaking work has been carried out by Dr. Douglas Spiel, who has developed an extremely innovative device called the IntelliCath. And what the IntelliCath is, and what it does, is allow patients with chronic pelvic pain syndromes to have their pain managed through the utilization of a percutaneously inserted catheter that delivers small amounts of local anesthetic and analgesic medications to a particular part of the autonomic nervous system. Now, this device is revolutionary in that it allows patients to be mobile, to be active, and to not have to spend weeks or months in hospital beds attached to pain devices or pain pumps. The other very significant advantage of this device is that it can be inserted with a relatively low degree of cost, which is consistent with a lot of the intent of the Affordable Health Care Act, which is the development of innovative, low-cost, high-quality devices. So Nine decided to go and interview the inventor and the brilliant mind behind the IntelliCath, Dr. Douglas Spiel. Dr. Spiel, thank you for taking the time to sit down with Nine and offer your opinions about the field of pain management. But to start off, you're a physician and you have a very impressive training in radiology and then interventional radiology. But why did you decide to subspecialize in the treatment of pain?
So, in medical school, I think we all decide on a field of practice for reasons that are frequently out of our immediate control. Some of our friends have gone into a field. We had a professor that we liked in certain fields, and that's kind of propels us in one field or the other. I enjoyed certain aspects of radiology. I was a level 1 trauma radiologist for a while, but I really missed being hands-on with patients. You're a doctor's doctor in many respects, so that you get to work hand in hand with surgeons and other physicians, but you're frequently directing care without doing anything yourself. And the hours in dark rooms affected me. And I really wanted to do more. And I wanted to be able to integrate all of my skill sets together and not just reading materials.
Now, pain is, with cancer and diabetes, one of the main contributors to healthcare budgets, not just within the United States, but globally. What do you think, or what would you say is the main reason as to why pain should be treated?
And I think we really need to break pain into maybe two separate subtypes. We deal with acute pain, which is very many ways anatomic pain. You break your foot hurts. You have diverticulitis in your belly hurts. You have an appendicitis. You have a rotator cuff tear. Those are acute pains. And acutely with surgical pain and cancer pain, those are pains that absolutely have to be downregulated. And when you heal from whatever the injury is, the pain will get better and you'll be able to taper off your meds. You need to contrast that with chronic pain. Chronic pain has a way of kind of rewiring our nervous system. We have a very homeostatic situation set up with our nervous system. We have pathways running down from our brain and our spinal cord that actually downregulate pain. And we have sensitizing fibers that run out from our periphery, from our arms and our legs and our belly and our pelvis and our chest, and run up and transmit pain fibers through the spinal cord up to the brain. In a normal situation, there's an appropriate reaction to painful stimuli. I bang my hand, ow, that hurts, but it doesn't hurt all day. People who have chronic pain have a dysregulation of the nervous system. We call it neuropathic pain. The injury comes and goes, but the pain persists. For those people, we offer forms of neuromodulation, ways that we modulate the nervous system. We modulate the nervous system with spinal cord stimulators, pumps that we put intrathecally in the spinal canal to place medications like opioids directly into the cerebral spinal fluid. And in many ways, we can do certain nerve blocks, although they're done peripherally on the outer aspects of the body, they work centrally in helping to downregulate chronic pain.
Now, medicine has a very unique language, and you've used some medical terminology, and I'd like to just ask you to explain what neuromodulation in lay terms is.
Okay, I probably slipped that one through and I'm sorry. We modulate things in order to make changes. Our nervous system is wired certainly with nerves and portions of the brain that are fixed. But although the nerves themselves are fixed, how they fire and what causes them to fire more or fire less is very plastic. We can change the frequency of firing, stop the frequency of firing, and in certain things increase the frequency of firing. And that's what I mean when I use the term neuroplasticity. There is an anatomic aspect, there is a map of your spinal cord and your brain. Your brain doesn't change in appearance, but the inner wirings of your brain are plastic to the degree that even after we do nerve blocks peripherally in our body, we can see changes in blood flow in the brain so that we know that we're seeing things centrally. And we talk about the central nervous system, the brain, the spinal cord, and the peripheral nervous system. Even changes in the peripheral nervous system affect changes in the central nervous system, which can affect the perception of pain in the entire organism.
Now, one of the aspects of pain management that has been getting an increasing amount of attention within the last couple of years is the management of chronic pelvic pain. in both men and women. And you've done a lot of research and made some very innovative steps in this arena. But could you just tell us, why do you think pelvic pain was ignored for so many decades?
You know, we are guilty as physicians of frequently looking through rose-colored glasses that bear the same tint as the specialty that we operate in. Gynecologists see a lot of problems with the gynecologic system, the ovaries, the uterus. Urologists tend to see a lot of problems with the bladder. Gastroenterologists see a lot of problems with the bowel. And when we see our patients, we look at them through our subspecialist rose-colored glasses. The big problem with chronic pain, as I alluded to before, a lot of chronic pains do no longer have an anatomic basis. What does it mean? It means that if I had rotator cuff tear and I had shoulder surgery and my rotator cuff is fixed, but I continue to have burning pain in my shoulder, is it possible that operating on my shoulder 6 more times won't make my shoulder any better? And yes, it is. I think if we've committed an error as a medical population, the big error we've committed is that we believe that we can fix everything. I have a hammer and I can hammer in a nail and the picture will stay up. Unfortunately, not all of the body's afflictions are amenable to a hammer and a nail. What we're looking at is trying to fix things based on an anatomic understanding, when in fact, the problem with the physiology, the way the body functions, doesn't subscribe to that. So when we look at a lot of these chronic pains, we can liken patients who have chronic pelvic pain to patients who have RSD or complex regional pain syndrome, reflex sympathetic dystrophy. These are patients who develop a traumatic insult, surgery, a broken bone, a nerve injury, and they develop a sequela of pain. They have allodynia. You can't touch their skin. They get swelling. They get functional changes in the musculature, and they get to the point that they can't use one or more of their extremities. When we look at the initial trauma, it's been healed. And what we're looking at is the sequela of the nervous system being upregulated. And there are treatment options afforded these patients. Unfortunately, with chronic pelvic pain, to date, I think the majority of patients have been tried to fit into an anatomical basis, and that's incorrect. Example. About 65% of female patients with chronic pelvic pain, we're talking about a huge number of patients. We're talking about 1 out of every 7 women, 15% of women between the ages of 18 and 50. Of these 10 to 20 million women, 65% have interstitial cystitis, which is a problem in the bladder, and endometriosis, which is a problem in the gynecologic system, and they coexist. 3/4 nearly of these patients have more than one organ system involved. How is that possible? I think the premise is that they have symptoms in more than one organ system. And the reason for that is that the nerves that come down into the pelvis pass through a relay station. And that relay station contains all the sympathetic nerves that go to the ovaries, the uterus, the bladder, the vulva, the vagina, and even the external genitalia. And when these patients have pain, some of these sympathetic nerves go to the bowel too.
So Dr. Spiel, what you're saying is that with chronic pain, it really doesn't matter which part of the body is initially injured. What actually occurs is almost a resetting or a dissetting of the internal nerve mechanisms. And within the neurological system, I mean, there are two main components. There's what's referred to as the somatic nervous system, and then there's what's referred to as the autonomic nervous system, which you referred to before. So could you just explain what exactly is the autonomic nervous system and why the humans have it?
So the autonomic nervous system is very important for homeostasis. Sympathetics allow you to perform flight or fight responses. They shut off certain body mechanisms and turn on other ones. Similarly, the parasympathetic system is very important for normal activities, bowel, bladder, things like that. And it doesn't participate significantly when you're trying to get away from a stress or something like that. Now, the autonomic nervous system works in concert by itself and generally functions perfectly. In some individuals with certain traumatic insults, and it doesn't matter what the traumatic insult is, endometriosis, well, you could have had the traumatic insult of menses. Women have menses every month. That's a traumatic insult to the pelvis. Urinary tract infections, pelvic inflammatory disease, irritable bowel, the spasm of bowel, even if you don't have inflammatory bowel, like ulcerative colitis or Crohn's disease. All of these things are insults. Give you an example. I have patients who've had pain just from having ovulatory treatments to try to ovulate so they can have children. That's an insult to the pelvis. If you have a sexually transmitted disease and you develop pelvic inflammatory disease, whether it's gonococcus or chlamydia, those infections clear. Maybe you've been a young girl who've had endometriosis and you've used the pill since you were 13 or 14 years old to control your pain. But the pain you have is no longer cyclical. And you get scoped. And they put a scope in your belly and your pelvis, and they find adhesions, but they're not well vascularized. They don't have a lot of vascular structures in them. They're old adhesions. They don't see any active disease. You've had bladder infections, and they do your urinalysis, and there's no bacteria in there. And when they scope you, there's no Hunter's ulcers. Hunter's ulcers are a hallmark of interstitial cystitis, but they're only found in 10% of interstitial cystitis.
Now, Dr. Spiel, you've been looking at the arena of pelvic pain, and you've described a lot of the causes in women as to why they experience pain. But you've also been very instrumental in developing a particular device called the IntelliCath, which is a device intended to help manage chronic pain symptoms in the pelvic region. Could you tell us what your inspiration and your thought process was when you developed this device?
You know, I looked at problems with placing catheters about 5 or 6 years ago. And there's very good literature that I had read maybe half a dozen years ago that suggested that nerve blocks done 1 or 2 or 3 in a row are good at downregulating the nervous system. But in some patients, they were able to do a continuous nerve block, place a catheter, put medicine through it adjacent to a nerve, and drip a numbing medicine and anesthetic over a period of 7 to 10 days. And when they pulled the catheter and the nerve woke up again, if you will, the pain was completely ablated.
Now, on the table in front of you, you actually have an IntelliCath. Could you just talk to the viewers and describe the device and kind of explain how it works?
It's rather simple. For those of you who've shot arrows, the IntelliCath is very simply a catheter. By a catheter, it's essentially a tube that comes with a stylet. Through the tube, you can run a medicine. And at the very distal portion of the tube, there's 2 holes that let the medicine come out. The importance of catheters when we're blocking portions of the nervous system. We block portions of the nervous system in 2 ways. We do parallel blocks, where we put the catheter just along the nerve, and we do that on a lot of peripheral nerves. And that's rather easy to effectuate a block, because if the catheter slips forward or backwards, then we still get an effective block. Now, the area of the nervous system that I'm blocking, for the pelvis, the catheter needs to be adjacent to it, because we're doing it in an orthogonal or perpendicular approach. If the catheter is here, it's no good. If it's here, it's no good. And if you just try to tie a catheter to the skin, every time you move, this happens. What I've created is a series of tines on the catheter that, once the catheter is deployed or placed through a needle, the needle comes out, the catheter remains, and when the catheter comes out to the skin, it's attached to a pump that has a reservoir, and it instills anesthetic or a numbing agent for 24 hours a day for a period of 7 to 10 days. At the end of that period, I simply pull the catheter. It took us a number of years, engineering-wise, to place these little tines on this catheter. I know it looks simple. The catheter is made out of a polymer very similar to the ones that are used for indwelling long-term catheters. And originally, trying to solvent weld the tines on proved relatively futile, because we couldn't get them to stay on very well. So what you see here, these are the end products. The catheter and tines come out of a single mold. And as they come out, these tines are very, very well connected to the catheter. We've done animal testing prior to humans, and they're very robust and withstand pull pressures to about 3 pounds or so, which is required in order to keep it in your body. The catheter also has a very interesting core. It's spring wound, so there's a slinky inside of the catheter. That allows it to never kink. I could put the catheter in with a knot and still infuse medicine.
So one of the advantages, it seems, is that this catheter can be implanted in a very minimally invasive fashion, and patients can continue to remain mobile. There's no need for them to be attached to any type of drip or be in a hospital bed, as was the case in the past.
So in the case of the past, this wasn't a viable alternative for people, because we didn't have a catheter that would even stay in place to block these certain nerves. In this scenario, you'd come in either to a surgery center or hospital. I would see you first in my office, and I'd ask that you have clearance. I don't want to see anybody with active cancers or infections, so that you receive clearance from your urologist or gynecologist or urogynecologist. We do a history. You'd come in the day of the procedure. Someone would have to drive for you, because you get conscious sedation, which is an intravenous, a line that they put medicine in. You lay down on the table, and under x-ray guidance in a sterile manner, 1 or 2 needles are placed in your back to the area adjacent to your spine, where there's this relay station that allows these sympathetic nerves to come through. Once the needle is in place, the stylet, or the inner portion of the needle, comes out. The catheter is placed through the needle is pulled out, the stylet of the catheter is pulled out, and then ultimately you're left with the catheter adjacent or next to the nerves. The catheter gets externalized onto the body, a little opsite dressing, which is an occlusive dressing. It then gets attached to a pump. The pump is set to deliver a certain amount of medicine over 24 hours. And every 3 days you come back to my office to refill the pump, where we can go over your symptoms and how you've been feeling. After about 2 refills, on about day 8 or 9, you come back in and we remove the catheter end block, and you go back to your usual activities of daily living. Now you're allowed to go home. You just have to take care of the fact that you have a pump on for a week, and you can do your usual activities within reason.
Now, as you had talked about earlier in the interview, pain is a very universal and global experience, and it would seem that your invention, the IntelliCath, is going to have applications in many parts of the world. Pelvic pain is it's a common female problem. So, in your opinion, do you see this technology expanding into other healthcare markets?
I do, not just in other healthcare markets, but allow us to treat other afflictions. So it's very handy to have a catheter that will block the sympathetic nervous system, because the sympathetic nervous system also controls vascular tone. So if you had an arterial ulcer in your foot or your hand, I could put this adjacent to the sympathetic nervous system responsible for the blood flow to that arm or hand and help heal that. This could be used to help heal skin flaps for patients who go home with surgical wounds, and the physicians want to keep a certain amount of anesthetic numbing agent on board for 3 or 4 or 5 or 6 days. You could drop this in the surgical bed, attach it to a pump to control local pain, and then after 5 to 7 days simply pull it. So the applications to this are myriad. I originally came up with the idea of the catheter for CRPS or RSD patients, and there's a great utility for those patients as well. They number about 1 million patients in the U.S. Interstitial cystitis, endometriosis, chronic pelvic pain in women, that's about 10 to 20 million women. Men who have chronic pelvic pain frequently have chronic prostatitis. That combined with interstitial cystitis in men, we may be looking at 3 or 4 million men in the U.S. just with that affliction. Foot ulcers, there's about 1 million. Many of those are venous, but for the arterial portions, this is useful. I don't have at my fingertips the numbers for skin flaps or some of the other diseases, but I think the utilities are myriad.
Well, Dr. Spiel, I'd like to thank you very much for taking the time to come on to Nine and give us your expert opinion about pain and about pelvic pain and the innovative device, the IntelliCath, that you've developed and will assist women all over the world in the management of their chronic pain. Thank you very much.
I want to thank you very much for having me on this show.
Welcome back, ladies and gentlemen, and I hope you enjoyed the interview with expert Dr. Douglas Spiel about his invention, the IntelliCath, and about pelvic pain. The IntelliCath, I'm pretty sure, will provide a global solution to a global problem. Pelvic pain, particularly in women and also in men, as I said earlier, has been one of the most ignored pain syndromes, but it's also one of the most consequential. Untreated pelvic pain has an enormous downside for quality of life indices for people. It interferes with functions and activities of daily living that most people take for granted, but patients with pelvic pain are acutely aware of. So I think that Dr. Spiel is definitely on the right track, and I think that his device will find a very receptive market, not just here in the United States, but globally. And I would like to thank you all once again for watching this episode of Nine, and good evening.